del tur po aniang voi ni theory kan chan na tur ni sela ti tak zatin kan zirdon nia du sang na sang berkalan chewa MCON principal organized to le heta kan joint director te tin kan health department na kan how to te zong le Lalhriatpuii tan he to pin thokila kan how to te thu oi ila chu karon cha du cheuni in zawai chunga lom thu ka hre chewa take care stay safe an tiang khan kan nun ipang tlang ang kalome
alom lu to sir hian in resource person turte arrangement min lo siam saka kan request te min lo ngai poimo sakin an ZMC faculty te le SRHF CND datin da beda mena so yang khanin staff nurse siam tak te ward superintendent te han anni in hemi class hi min lo conduct sak don ani chuan sarpo aboi chungin hun chep takkara te hun chatak miron de puya kan lo be mema itu soi kha kan lo share nga he training chung hianin kan naw te le zirtir tu te faculty te helai training ron eten zong te chuanin kan ril ruwa kan lo vong reng don ya ti kha kan soi te du ani chuan kan lom tu tuna kan next speaker tur lo som le ila Pilar Remoi joint director nursing lo som ang
Ole kalome boina Mizoram College of Nursing le ZMC tang wai hot le hi alom katia ni kumlam panga khan kawan ya heta doffing donning and doffing of PPE khan karon tel ve to a kha kan thil sia ma kha atang kai em me ya ti chuan zoram mun ti na keima ni tong ngein a practical ne na kan the dar kha andu huna kan staff ten min ron dila madam kha min lo thon le te he kan naw te kan zirtir du ten tia han tangkai takin kan manga voinya hian khanga bang khan lom thu ka sei du a chuan he kumina thatak main in han organize le ni a tiang hun tha mang theya ka hi ka loma joint director nursing ka ni ang po in lom thu ka sei du a nursing personnel te tan tangkai takin kan la mang le in ka be seya access thein keima ni tung ngein in training ang diak ni lem lo po in midang te man tangkai thei turin keima ni tungin lo da le thei ula karon request du chewa chuan hei topic thatak tak mai covid related apoi mo zual kar khachunga zirtura me in ka sia a resource person thatak tak mai kan han nei le boka ataka practicala amuna titu ho ngein min han kai hruai don ania chuwangin abuat sai tu te chunga lom thu ka soya tin kan thil ti reng a hian ti tak zeta kan ti hi atha a lo tling thina keima ni po satisfaction kan nei thina zirlaite he kan expose don chuni a second wave a hi chuan in bang thei big lova tutors te po in bang thei big don lova kan zawa in hey health worker teng te pon ni thowa GOI in thu a chua tun ma te chuan rapid antigen test te po ti turin kan be sei vak lo lab technician ten an ti mai thina tuna hi chuan rampum puya hian adar na sto lu chuka chu bang chuan health worker te thlengin assign bel an nia kan na tur hi pek bel kan ni hloma chutiang che chuan zirlai te po tuna chuan GOI in min han put to ania ama ero chu kan ngai thlak tu ang khan keima ni inveng thiam chunga kanin expose angaya professional nurse chuan infection control azirin athiam turania chu nangma ni theu kha eng angin nge ka invent theyang ti te in lowin ngai to a physically te mentally te a in fita technically a in skill a in invent thiam hi apoimo emani kan the vanar sting te chuanin tarte te thleng pon veng chunga te kan mu ani heng tiang hi eng wange kan ti chuan an na an rin oma chu wangin an survive rei bokani chu wang chuan nang ni po film khur taka in ti chuan in survive nge yang chu ka cha du chewa tai mat takin in ti anga pathian tanpui na in la anga in ti chakreng anga chu tiang chuan ral matonga amo ral do turin covid ral do turin in buat sai don ani a kan mi huai kal masate niak nung zuin huai sen takin in lo pen chuak anga kan pen chuak zelanga hei epidemic te pandemic te kan lo tong fo to a changin H1N1 te nipa virus te po ni thowa khatiang khanin kan lo ton tlang fo to thina nang ni po zirla in ni lain hetiang ang hi in lo tong ta hlo meya po ni se hei hi acham ring lovanga engtika mo chuan min lakiam san ve meyanga khang kha heng hun la ya in experience hi in dam kho chwa puyanga nakin zela midang te tan thon thu nga inom te po ala chang ve thei don ani chuwangin vai sen takle tai mat takin in ral dong tur in dowanga in survive nge turani ti hi karon ngen du chewa tai mat takin in buat sayanga pathian tan puina in ne anga in kal tlang nge yang ti hi karing tlatani chu 4th year chang ni lovin year dang te po in public service tur hi in lo pomve ate po angaya tin experience chatak ani choboka public tana service ani baka hian entirnan mai ICU ate po in lakal ve tho theya tin mild to moderate ate po khan ani tho theya damlo position change ringo po hi mi pali pangate angaya ni critically ill patient da chuan khangkha technical skill in zuk perfect thelo ani point in observe pa po khan midang te tan mal som na nasatak ani the ani critically ill patient engi moza kan nei to a tuna po ventilator mang som ni don kan nei le to ni khang ang huna te po khan in observe pa in engtiangin nge tracheostomy Varte endotracheal tube Varte engtiangin nge akhol ti chesti lovin a tube ti chesi lo le ti block si lovin engtiangin nge position and change ti te khang ang thil tam tak in tha tho pa khanin in va tan pui theiani hei hi thil poimo em ania tuna hian India ram pum puya le kan mi zo nurse te ngei po mun tam taka hian ICU te po an tangkai em a khatiang khan an mit meng le an kut chevel te le an tong ka chuakin midang te tan mai som na nas takan nia tiang chuanin mi thina hlim kora ommek te tana be seina eng te chuak turin na satakin tuna hian an thok me kani chu aro pui em a mi hianin an appreciate em ani khatiang ang profession vuan tu ra in pe te kan ni awangin kan tlan chethiang lawa chuan henga po hian nung changmoi te po apoi mo khop me hei pathian ko ngai na zara nursing superintendent ten hundrei takte kan oma tin kan nursing staff te po hi an tom ngai ka ti a heng huna hian min tlan chat san mai lawa thanem ngai takadam lo te ta na in a thok chuan an tam em a aro pui ka ti a ka thin lung hyang ka thei hil thin lova khang hun lai te kha mitla achama professional nurse dik tak hello ombe to thin te hi aro pui ka ti a mi tam tak mi mu lo le mi riat si lova thok ro pui ngai san om tam tak hi ka mu a ka thin lung an ne thina chung voina po hian ka chuang em ma kan nurse te tu na thok mek te pension to te po an nia chu tiang anga he na atan na lo in pe to te kan ril ruin kan hrenga tin har sat na awang te mi ban doi te tam tak he na atana an nun hlan te po kan ril ruin kan hria kan za a kan choi moya kan chuang em ani chungkara chuan huai sen tak le him taka thok thei turin in buat saya in thin lung in ti pau khawa in he challenge in accept phi ka du em ani ti chuan voina hian thu tam tak han soi na chi ani lo awangin khang ho te kha kan du tok don maya nga a ming maya mo phurna ti thling tlak tum ni lova manga ina nen dam lo te that du tak tak na ne na lo pen chuaka in che zia a ron ti lang turin ka du chewa hei lo hemi mas kan wa chung po hian mas chung chi a kan mit meng lo lang hi apoi mo ma hei hianin dam lo wa be se na sang tak a hlim na te a pe thei ani chu wangin in mit meng in that du na dam lo ta na that in chwa na te le khatiang be se na mit meng eng khan dam chak na te a pe ani ti sha in service pe ka te tan thamwan na thlen tu ni turin ka du chewa lalpana rul don chewa chu wangin arem chang in nei anga thil tha lo te ta na ti turin karon ngen du chewa hezir lai kan ni lai hian thil tha tam tak te a ti ve theya zir lai kan ni lain voina hian a challenge satan kan soi mei du chu zir lai kan ni lai khan thisen hi voi thum ka pe ve man na pasal nei te kan lo du a tin pasal kan nei zo changur tam takalo oma khanga khanin thisen pek te po hi chance hi awang to thina ni azir lai kan ni lai te hi kan that hun wang lai ani a chu wang chuan khatiang dam lo mang ang nun na chan ngai midang si lo a khang tiang hun te in tong ani chuan thisen pek te po hi she lo ula tin mi tam tak poinin pe to ang ti ka ringa khang tiang anga lo che chuak to te chunga voini hian thin lung takin lom thu ka soi du a tin chu tiang ang chance la nei tu te tan te po a kan thin lunga kan du sak na mai ba ka khan ke ma ni ti thei sang ber dam lo te nun na chan na tu ra ta na kan thisen te kan han pe phala kan han thok te hianin kan na tho hun chung zongin job satisfaction te min pe a chu kan tan po a tha a chu wang chuanin khatiang ang te thlenga thil ti thei tur khan in thin lung in buat sai ka du a chung chu karon cha du bok chewa thei pato pin thanem ngai takin he profession za na keng nung zel tur hian karon cha du chewa mitam takin that takin an lo len chuak to a khatiang kha keng nunga professional nurse puitling inni theina tur ta na tu na inin buat sai na zong te ti hlo thlinga chuan taka thok chho deuh turin le survival instinct sang tak neya ne na chang chho ze turin du sak na ka hla na cheu ka lo me
alo om lu to ke madam hun chep takara kan som na te min ti hlotlin saka kan lom be mani madam hi joint director nursing ani a Mizoram nursing a chuanin kan ho tu poi mo tak ani ti kan she chewanga tin chu ba ka chuanin nurse organization TNAI kan shevek anga chu ta chuanin Mizoram branch a president ani bokani athu soya changa kalongai poi mo deuh pakhat kan soitel kan zeptel shram du a nursing spirit kan nei apoi mo zia kha aron thai langa chu ke mani chewa po hianin into tumila ke mani lam atanga kanin open lo chuan ani thei ani lova chu wang chuanin athil aron soi poi mo tak nursing spirit kha kan nei cheu thei nan kan zawai tan du sakna kan lantel ve nga lani tikhanin kan inauguration program chu kan zo ani maya minute reilo te la oma ta hianin zirlai te lampanga changkhanin zona emo engemo hansoi du kan nei ani chuanin hun in honglok te ang kan om lem lo ani anga principal ma'am hian
mute ta hian han an mute le phot thenga ya a flow here lo fu lo chon boy thak thina an zir lai te andil ruwa zo na a om karinga in tun hun hi zo na te enge mo nang mania indil ru kap tu alo omani pon soi chwa na hun ani ti kha ka sai duwa mizo hi zo na omem han ti hianin student ni wang hian nge ni kan rong chuak shetlat zela hi apoi katia ka tun hemi ma voin hemi program kan man ma po hian in coordinator te kal tlangin inril rute kan lo thot lok to chewa ta khan enge ni zona te po kha in nein ka sha voina hian khang ang zona in nei te inril ro om te kha he kan join director nursing te om lai te director ZMC po khala min ka ala omem min la join manem an boy ema om man to lo po ni me thea clarify ngai te om chuanin kan tan ma hianin nang mani ril lo kap deuh tu te in lo eng hel deuh te khathila omem ti kha ron soi chuak hre su tu na han soi chhuana hun ani ti kha kan soi ve lo ka ni chu Supriya zona name da zona ni Supriya a om lo an yang ma pui ani chuanin carry on
ni han soi deuh te po kan share te po ni mai the mani 40 year ho ne na kan discussion kan han nei pui kha chuanin enge an kan ramina min mo ani chuan kan duty anga ani mai mo na asan chuan kan duty chu kan in pe renge ti in an ron soya an mani ril ro om ber kha chu enge an safety chungchang chu thukhat ni se nu le paten an ngai to atur zia kha enge an ron soi ve kha kha chu om renga no students lam panga chang chuan khang te kha kan issue han sei deu chu ania ama ero chu kan sha thiam da na chuanin an di po enge mamo na om chuan duty thei khanin anin ring reng ani ti kha kan madam te sha ta kan sei tel du ani chu chuan kan inauguration session hi zoa chuan class kha theory class kha kan chan mei do na nga madam te po in boy via win karinga eten du chuan kan la som reng chewa amai ro chu kan man lo ani chuanin leave kha in thlashung lawila ti kha kan sei du a pujo na po hi om to lovin ka sha ni china kan zong dewa ka mu to lawa shan pa lom thu han soi le po kha ka cha ka amai ro chu ani po aman talaw ani ange alom ome hun te chatak kan nei theya chuan session te tlong taka kan kal theinan te min lo chongchai pui turin madam te po kan som ani kan lom lu tu ke chuan session he 10:30 ka sana hian ri chi a kan first class tur kha kan chan mai anga punctual the win nursing ni angin mo punctual de khan hun hi an mangila tuna introduction to COVID-19 group dang class dang ron eten ho khan in kan topic ka kha in lo she lo me thia chan chu atira khan kan ron share vak lo wangin emi group in nangmani WhatsApp group class tina khan in zirtir tu ten an ron share zelanga class hi kan ka som mai kan soin non le lok du chu atam kan tia mai ro chu rei lo te ania daytime affect class ni do na chu i kan class po kha kan lo in siam rem mai in karinga internal lampang chu mi ni wang chuanin eni danga po hemi link ngai a tho hianin a timing a khan kan ron attend ve zel don ya zirlai te po khan chuan miss Lalhriatpuii Varte senior lecturer lo so mang
kan speaker tura in bo sai chungin kalo sai du chu hey exam hi MZU hian ahun asona ni lo chuan July kha alasten tu wang chuanin tun hun hi hun lekha injir hi thulo ula ti kha kadua zirlai zong te kha nakina in duty chuan in ha dona injir thape lo mai thei tu wang chuan thei top cho in hun hi waste lo ula zana mo jing ani mo jing te po ma tak tak thowin hei finally tan phei chuan hei rei lo te in thei top in chwa chuan result lo bom tak in nei theya tu wang chuan in time waste lo turin kan chap le du lok chu kalome
Có trong in sẽ thêm ó
yes miss
kha thei
te thei
ale the khan class content mop panga good morning everyone so today we shall start our class that is introduction to COVID-19 and we will deal about WHO overview and the clinical manifestations. First of all, let us see a brief history of the COVID-19. On 31st December 2019, China informed WHO, the World Health Organization, about the cases of pneumonia of unknown etiology, that is of unknown cause, in Wuhan city, which is in Hubei province of China. And in 7 January 2020, the new disease was initially named 2019 novel coronavirus or 2019 nCoV. Then in 30th January 2020, WHO declared an outbreak of public health emergency of international concern. Here it was not yet declared as a pandemic, but as an outbreak of public health emergency of international concern. Then on 11th February 2020, WHO officially announced a name, COVID-19, for the new coronavirus disease. And what we have to know is that coronavirus was first identified in the year 1960, and there are different types of coronavirus. So the new virus, the new causative virus, which is named as severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2, and this virus is contagious in humans, and it is a successor to SARS-CoV-1, the strain that caused the 2002 to 2004 SARS outbreak. So here, what we have to understand is the name of the disease is COVID-19, and the causative virus or the causative or the name of the causative virus is known as severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. The name coronavirus is derived from Latin word corona, meaning crown or wreath, due to their crown-like projections. And the full form of COVID-19 is CO stands for corona, and VI stands for virus, D stands for disease, and 19 stands for 2019. That means the year in which it was first identified. So on March 11th, 2020, COVID-19 pandemic was declared by World Health Organization, and the pandemic is the worldwide spread of a new disease, as per the definition of WHO in February 2010. So it was declared as pandemic on 11th March 2020 by WHO. Now coming to the origin of the virus. Virus circulate in a range of animals, not only this SARS-CoV-2, but any kind of virus, it circulates in a range of animals. And there is a term which we need to be familiar with, that is spillover, or in some references you will see it as a zoonotic spillover. Here it means the spread of or the circulation of virus from animals to humans. And this might be due to various factors such as mutations in the virus. So the mutation in the virus makes the virus more susceptible to be easily transmitted from animals to humans. And the other reason might be increased contact between humans and animals. So for example, MERS, Middle East Respiratory Syndrome, cough, which was seen in Saudi Arabia in 2012, that was transmitted from camel to humans. And SARS-CoV was seen in China in 2003, and it was known that disease was transmitted from cats to humans. Another animal reservoir of this new virus is still unknown. There are many predictions, but the actual animal is not yet identified till now. Now, coming to the scenario of COVID-19 in India, the first case was detected on 30th January 2020 from Kerala through the 3 students who returned from the area where it has originated, that is Wuhan, China. And the first death was reported on 12th March 2020. The first victim was a 76-year-old man who had returned from Saudi Arabia. And India currently has the second largest number of cases in the world, second to USA. But from the next slide, we'll be able to understand the actual condition of the present scenario in India. So this is the WHO weekly report as of 3 p.m. CST, that is Central European Summer Time. This is CST if we compare with Indian time. Indian time is 3.5 hours ahead of Central European Summer Time. So it was this report is as of yesterday. So the global case was the global case as of yesterday's report was 162 million cases. Identified all the confirmed cases, and the number of deaths in the last 24 hours was 12,034, more than 12,000. So in USA, if we compare the condition of USA and India, the total number of cases in USA is higher. That is 32 million, more than 32 million, and in India it is around 24 million. But if we look into the new cases in the last 24 hours, that is in the second column, USA has only in the sense USA has new cases of around 40,000 in the last 40 hours, whereas India has more than 3 lakh new reported cases in the last 40 hours. And the number of deaths, if we compare again, the number of deaths in USA during the last 24 hours is 680, whereas it is more than 4,000 in India. And we will see the condition of Mizoram. This is as per report of the of INPR in, this morning. So the number of total cases already number of cases is 28. Now in 59. So this table will but the number of for hours here in this is just for our knowledge. State in India declared COVID-19 was Punjab, and the first state in India declared lockdown was Rajasthan, and the public curfew known as Ajanta curfew was imposed on 22nd March 2020, and government of India announced lockdown phase 1 from 25th March 2020 for 21 days. And between 14th April and 3rd May 2020, the Prime Minister extended the nationwide lockdown followed by 2-week extensions. Then coming to points regarding the increase in the number of cases, there has been a steady increase in the number of in 2021. Number of cases among children and young adults seems to be higher than in previous periods of the pandemic. That means the number of cases in the first wave. So the number of cases in second wave is we've seen the number of cases first wave, and this may be contributed by 3 factors. These in the sense the rise in the number of cases. Number 1 is changing adherence to public health and social measures, resulting in increased social mixing. That means we have let our guard down. So maybe we become lazy to wear masks. We become lazy to we neglect to wash our hands frequently, and also we started social mixing. And another thing is circulation of new COVID variants that are more transmissible. We will talk about this later. Uneven or unequal distribution of vaccines. So we know that even in India, our scenario is such that in the beginning, when it was developed, our government has exported vaccines to other countries. But when the second wave came, our government is lacking the number of vaccines which is available for its own population. So that may be one of the reasons which is contributing to the number of the rise in the number of cases. The marked rise in number of cases in India is largely attributed by religious and mass gatherings such as Kumbh Mela in 2021, as we have known, and state assembly elections was also conducted in various states like Assam, Tamil Nadu, Kerala, Puducherry, etc. Inadequate vaccination, as we have already mentioned, and small gatherings. Small gatherings tihan, entiyonan ki mani ang atsan inne te manhan ti te birthday lom ti ver te po anyang birthday lom te tin picnic ti te tin subaka chuanin ramaria ti te hang te po kha engeni anin ti mo na sa manyaw maya katyang te po kha it can be it can come under small gatherings. These are also the contributing factors in other countries with rising number of cases. So the rise in number of cases is seen not only in India but also in other parts of in some European countries as well as in Southeast Asian countries also. Then when we let our guard down, the virus takes the advantage. Kay mani na katuna hiyan alare veklo he virus angyan kan lapire law vaccine po kan la veklo sumini wan chuan kan kay mani kan in thada chuan the virus will take the advantage. So we will see the rise in the number of cases. Let us see the scenario of COVID-19 in Mizoram. On 10th February 2020, the first suspect we had a first suspect case, but it was not positive. And 24th March 2020, the first positive case was detected. And on March 9th, 2020, the first positive case in Mizoram was discharged from ZMC. And on 7th April 2020, the first RT-PCR was done in ZMC. Before this, the samples had to be sent to Silchar. And on 11th May 2020, the number of cases in one day was seen on 11th May 2020. Briefly on vaccine. In India, Prime Minister Narendra Modi virtually kicked off India's massive coronavirus vaccination drive on 16th January 2021, which was expected to cover 3 lakh frontline healthcare workers across 3,006 sites in India. As of 11th May 2021, 1,264 million vaccine doses have been administered globally, and in India, around 182 million doses have been administered in India alone. Okay, now coming to the case definition. Here we will have 3 terms that those are suspect case, probable case, and confirmed case. So we will try to understand what is the meaning of suspect case, probable case, and confirmed case. Number one is suspect case. Suspect case means a patient with acute respiratory illness, such as fever, and at least one sign or symptoms of respiratory disease, such as cough and SOB. So that means the patient will have a acute respiratory illness like fever, and along with that, the patient will have either cough or SOB or both. Also, a history of travel to or residence in a location reporting community transmission of COVID-19 disease during the last 14 days prior to the onset of the symptoms. So the patient will have having acute respiratory illness, that is fever plus cough or SOB or both, and travel history or residing in a location who is reporting community transmission of COVID-19 disease during the last 14 days prior to onset of the symptoms. So this is number A. Or another suspect case is a patient with any acute respiratory illness, as I have already mentioned, and having been in contact with a confirmed or probable COVID-19 case in the last 14 days prior to case. Probable case means a suspect case for whom testing for the COVID-19 virus is inconclusive. That means test has been conducted, but the result is inconclusive. That means there is a chance of positive or negative. Then another one is a suspect case for whom testing could not be performed for any reason. So this might be reasons such as unavailability of the test material, unavailability of the workers or healthcare workers to collect the samples, etc. Then number 3 is confirmed case, a person with laboratory confirmation of COVID-19 infection, irrespective of clinical signs and symptoms. So the person might not have any clinical signs and symptoms, but if it is confirmed with laboratory testing, then that person is a confirmed case. So these are the definitions of suspect case, probable case, and confirmed case. Is there any query until up to this point?
No, Miss.
Okay. Okay, can I proceed?
Miss, suppose that an individual have no symptoms but is still in contact with a positive patient, at what category will be that individual
So, I'm sorry, can you please repeat? Can you please repeat the question?
An individual have a positive, have a contact with a COVID-19 positive patient, but
Okay.
that individual doesn't show any signs or symptoms, doesn't have any signs
Okay.
or symptoms yet.
Mhm.
At what category will be that individual will be
So
considered?
if he is having a contact, then that person will be a suspect case. But as per the updated guidelines, the patient that person will be kept for quarantine or in isolation. Okay. So according to the if there is a confirmation of positive contact, then he will be isolated for a number of days as per the government of the updated guidelines. So after that, test will be conducted for him. So if it is confirmed with laboratory diagnosis, then that person will become confirmed case. Is that clear?
Thank you, Miss. Yes, Miss.
Okay. Now coming to the clinical features, I think these are all very common. You must already be acquainted with these clinical features: fever, cough, fatigue, shortness of breath, anorexia, myalgia, that means muscle pain, sore throat, diarrhea, sore throat, headache, diarrhea, nausea, vomiting, anosmia, loss of sense of smell, and ageusia, loss of taste. These two, anosmia and ageusia, usually they precede the onset of respiratory symptoms. So these two might be the first signs and symptoms in some patients. Rhinorrhea, nasal congestion, these are also seen, but it is not very common. So if we look into the data, then we can see that most of the patients, that is more than 80% of the patients with confirmed case have a complaint of fever, and cough is also quite common, and usually it is a dry cough. Then fatigue is also very common, and shortness of breath, especially in the second wave. Shortness, the number of cases, the number of complaints, that is shortness of breath is much higher than in the first wave. Then older people and in continuation with the clinical features, older people and immune suppressed patients in particular may present with active symptoms such as fatigue, reduced alertness, reduced mobility, diarrhea, loss of appetite, delirium, absence of fever. Children may not have reported fever or cough as frequently as adults. So the clinical features which are discussed here, which are mentioned here, this might also be seen present in older people and immunosuppressed patients as well as in children. But what we have to know is that in when we assess the older patients, older people, and patients with immunosuppression, and among children, we have to look out for these clinical features, especially in these three groups. So fatigue, reduced alertness, reduced mobility, diarrhea, loss of appetite, delirium, and absence of fever. So they might not have, although it is quite common, although fever is the most common clinical features in COVID-19, it might not be present, it might not be manifested among older people, immunosuppressed patients, and children. Then COVID-19 mental and neurological manifestations, anxiety, depression, and sleep problems. These are very, very common among the patients, and other symptoms such as headache, dizziness, impaired sense of smell or taste, as have already been mentioned, myalgia, delirium or encephalopathy, agitation, stroke, hypoxic ischemic brain injury, seizures, coma, meningoencephalitis, GB syndrome. These are all seen associated to COVID-19, but the relationship between between COVID-19 and these manifestations is not clearly understood till now. So, but from their research, they have found that this type of manifestations are seen, or these features are manifested by the patients. So we have to look out for these manifestations. So this anxiety, depression, and sleep problems, these are very common, common complaints, common problems among the COVID-19 patients. So that is why counseling is very, very important for the patients. Mizoram ate po hey ingani counseling ingani online counseling ti theina chumi area chon chumi te tan chumi CCC ho chumi ho area tan chon chumi te chuti han order ron chin kha khami te khan online in telephone in mo khatang khan in counselor te kha anron theyani clinical psychologist te counselor te khan kha e counseling nei pui turin tyang khan anron theyani achan chu hemi case hi atam wangani. About 80% of patients recover without needing special treatment. So even if they are confirmed case, not all the patients require treatment in the hospital or treatment in requiring special care. So you must have heard that many of the patients, many of the confirmed cases are being isolated in the COVID care centers without being hospitalized in ZMC, but still they have been discharged after confirmation of negative results. Then group at risk are older people, people with underlying problems like chronic respiratory disease, obesity, diabetes, hypertension, cardiac disease, and cancer. Clinical manifestations are generally milder in children compared with adults. And the understanding of the mid and long-term sequelae of COVID-19, that is post-COVID syndrome or long COVID, is emerging. So we have to, this disease has been with us for about 17 months. So the long-term sequelae, the long-term effects of this disease is not clearly yet understood. But if we look into the videos or the interviews of the patients, the survivors of this disease, you will see that many of them are still complaining about anorexia, nausea, muscle pain, depression, fatigue, even after months or even after weeks of recovery. So this is, although it is not clearly understood, but we have to understand that even after they are cured of the disease, there are still some features, clinical features, which are present in the person. Now, coming to the mode of transmission, it occurs from both symptomatic and asymptomatic people. So whether symptomatic or asymptomatic, they can start through respiratory droplets. This with the infected person means if we are face to face and we are in close contact with the infected person, contact with contaminated objects and surfaces where there are droplet infections the droplet infections have landed from the patient. Then number 4 is aerosols, that is in the enclosed spaces or in those crowded and inadequate ventilated spaces where infected persons spend long periods of time with others, which may include restaurants, choir practices, fitness classes, nightclubs, offices, and places of worship, or during aerosol generating procedures. So aerosols means it is the fine those fine droplets or those fine solid particles are suspended in the air. They remain in the air for a certain amount of time. So these are usually seen in the enclosed spaces indoors and the crowded spaces, inadequately ventilated spaces. Okay, so these are the modes of transmission, that is through respiratory droplets, direct contact, and through the contaminated objects and surfaces and aerosols. But number 3, the contact with contaminated objects and surfaces. Nowadays, at present, it is said that the chance of infection, the chance of being becoming infected through the contaminated objects and surfaces is quite low, but it is not yet ruled out. Studies confirmed that patients demonstrate highest shedding of SARS-CoV-2, that is the virus, in the upper respiratory tract, nose, and throat early in the course of the disease within the first 3 days from onset of the symptoms. Onset of symptoms symptoms there is the highest shedding of the virus from the upper respiratory tract, that is through the nose and throat. And there is another study which suggests infectiousness peak on or before symptom onset, with an estimated 44% of onward infections happening during the pre-symptomatic phase of the index case. So in the first study, it was seen that they have concluded that there is the highest shedding of the virus within the first 3 days of onset of symptoms. And the second study suggested that the infectiousness peak on or before onset of symptoms, that means even before the patient, even before the onset of the symptoms, the person can transmit the disease to another person. Then infectious dose of the virus is unknown. That means we do not know how much amount of how many millions of the droplets is required to cause infection for a particular from a particular patient to another person. And the incubation period is on average 5 to 7 days, but it can be up to 14 days. During the pre-symptomatic period, some infected persons can be contagious, as we have mentioned just now, from 1 to 3 days before symptom of onset. Pre-symptomatic transmission still requires the virus to be spread via infectious droplets or by direct or indirect contact with bodily fluids from an infected person. That means we have said that the person can transmit the disease irrespective of his condition. That is, whether he is symptomatic or asymptomatic, he can still transmit the disease. So, but the mode of transmission in the asymptomatic or the pre-symptomatic person and symptomatic persons, the mode of transmission is still the same. So up to this, is there any query? Any question? Okay, now I will go to WHO severity definitions. This is adapted from WHO COVID-19 disease severity categorization. So the WHO has developed this COVID-19 disease severity categorization. So from this, to simplify it, the WHO severity definitions is adapted. Okay, so I'll just explain this in brief, and then after that we will go into details about the severity categorization. Number one is critical COVID-19. It is defined by the criteria for acute respiratory distress syndrome, sepsis, septic shock, or other conditions that would normally require the provision of life-sustaining therapies such as mechanical ventilation, invasive or non-invasive, or vasopressor therapy. So these kind of patients are classified as critical COVID-19. Then next one is severe COVID-19. Severe COVID-19 is defined by any of if the oxygen saturation is less than 90% on room air, respiratory rate in adults and children older than 5 years if the respiratory rate is more than 30 breaths per minute, and the signs of severe respiratory distress such as use of the accessory muscles like abdominal muscles, etc., inability to complete full sentences, and in children very severe chest wall indrawing, and grunting. Okay, grunting, abnormal sounds which can be heard during labored exhalation, and central cyanosis or presence of any other general danger signs. So these patients will be classified under severe COVID-19. So the risk factors for severe COVID-19 are age, more than 60 years of age, and it increases with age, and underlying NCDs such as diabetes mellitus, hypertension, and cancers. Then in pregnancy, increasing maternal age, high BMI, non-white ethnicity, chronic conditions, and pregnancy-specific conditions such as gestational diabetes and preeclampsia. And another one is smoking. So we have talked about critical COVID-19. Next one is severe COVID-19, and the next one is non-severe COVID-19. So these are the three definitions. Non-severe COVID-19 is defined as absence of any criteria for severe or critical COVID-19. So we have seen the criteria of severe COVID-19 and critical COVID-19. So if we do not find any of those manifestations, any of those conditions, then that patient is classified under non-severe COVID-19. But at the same time, what we have to be cautious about is that oxygen saturation. Here you will see that under severe COVID-19 classification, oxygen saturation less than 90% on room air. So, but what we have to be cautious about is oxygen saturation threshold of 90% to define severe COVID-19 is arbitrary and should be interpreted cautiously. Arin tla tok lo ani mo athatok lova amero chu he hi tuna an man chu ani thowa ma se I hetan film khurangai ta ni For example, determine whether a low oxygen saturation is a sign of severity or is normal for a given patient with chronic lung disease. So that means if a person has a underlying chronic lung disease, then definitely his saturation will be low, which is normal for the patient. So that is why not only for the patient with chronic lung disease with increasing in age, the saturation level will also be their normal level of oxygen saturation at room level will reduce. So that is why we need to understand the condition of the age, and as well as we need to consider the age of the individual, as well as any other underlying conditions which may reduce the level of oxygen saturation. So to summarize those three definitions, you can please look into this figure. Patients with confirmed COVID-19, so a patient has been a suspected case or probable case has been confirmed with a laboratory diagnosis with COVID-19. So the patient will be classified into three categories: non-severe, severe, and critical. Critical means requires life-sustaining treatment, such as mechanical ventilator and vasopressor therapy, as have already been mentioned, and acute respiratory distress syndrome, sepsis, or septic shock. So if the patient shows these signs and symptoms, then the patient is classified under critical. So it doesn't mean that the patient should show all this. Okay, the patient might show only one of these manifestations, only one of these criteria, but still the patient will be identified under critical. Then severe is SpO2 less than 90% on room air, as have already been mentioned, what we have to be cautious about, and respiratory rate if it is more than 30 in adults, as well as children more than 5 years of age, respiratory rate in children, and signs of severe respiratory distress. So these are categorized under severe. Then non-severe is absence of signs of severe or clinical disease. Any doubt up to this regarding this? Okay, I will proceed to the next point, to the next topic, that is COVID-19 disease severity. I have already mentioned that this classification has been adapted from the WHO COVID-19 disease severity classification. So we will go into details. Number one is mild disease. Mild disease means symptomatic patients meeting the case definition for COVID-19 without evidence of viral pneumonia or hypoxia. So thalo ko nga inlo man siang lo inlo takin WHO khanin hemi disease classification hi anei ta to disease classification a chan engani detail to min thil kha asyam ta ni amero chu khata tang khan all samzo ka engani all samzo ka identify thina to te all samzo ka kan I classify thina to khanin I tihanin hemi disease severity classification hi kami atang khan kami anmei na tang khan hi asyam thale ti na ni chu asyam le a all samzo ka kan man thei turang kha tu chu critical, severe, and non-severe ani ta ni tu chu a all samzo ka kha adapt chop pa kha ani ta ni chuan anmei zo ka chu atak tak zo atak tak han apui ber zo le a detail zo ka chu ti mayang a detail zo ka chu WHO COVID-19 disease severity hi hemi hi ni ta ni. So the number one is mild disease. Mild disease means symptomatic patients meeting the case definition for COVID-19 without evidence of viral pneumonia or hypoxia. So those the patient is confirmed from laboratory tests, and the patient is symptomatic. That means he's showing those clinical features, but there is no features of viral pneumonia or hypoxia. So the patient will be categorized under mild disease. And number two is moderate disease. That means there is a development of pneumonia. In mild, there is no pneumonia, but in moderate, there is pneumonia. So in adolescents and adults, clinical signs of pneumonia will be seen, such as fever, cough, dyspnea, fast breathing. and no signs of severe pneumonia, including the SpO2 will be will be equal or more than 90% on room air. That means it will be sufficient, adequate oxygenation. And in children, clinical signs of non-severe pneumonia, such as cough or difficulty breathing, plus fast breathing and or chest indrawing, and no signs of severe pneumonia. And fast breathing, it is if the patient is less than 2 months, the breathing respiratory rate is more than equals to or more than 60. And if the patient is 2 to 11 months, equals to or more than 50. If the patient is between 1 and 5 years, then the respiratory rate is equals to or more than 40. So in mild disease, there is no symptomatic patient, but without pneumonia or hypoxia. In moderate disease, there is a presence of pneumonia, but mild case, that is there is no signs of severe pneumonia either in children or adults. Chest imaging such as radiograph, CT scan, ultrasound may assist in diagnosis and identify or exclude pulmonary complications. So another thing which we have to be cautious about is, as have already been mentioned, regarding the oxygen saturation level. Then the third one is severe disease, that is severe pneumonia. Mild that one pneumonia omlowa, symptomatic without pneumonia or hypoxia. Moderate is moderate pneumonia. Severe disease is severe pneumonia. So among adolescents or adults, there is a clinical signs of pneumonia, such as fever, cough, dyspnea, fast breathing, plus one of the following. Any one of the following. So respiratory rate, which is more than 30 breaths per minute, severe respiratory distress, and SpO2 is less than 90% on room air. Among children, child with clinical signs of pneumonia, cough, or difficulty in breathing, plus at least one of the following. So the first one is central cyanosis or SpO2 less than 90%, severe respiratory distress such as fast breathing, grunting, very severe chest indrawing, general danger signs such as inability to breastfeed or drink, lethargy or unconsciousness or convulsions, and fast breathing, as have already been mentioned in the previous column. With the while the diagnosis can be made on clinical grounds, chest imaging such as radiograph, CT scan, and ultrasound may assist in diagnosis and identify or exclude pulmonary complications. So number 4 is critical disease. The fourth classification is critical disease. So under critical disease, there are other classifications again according to the disease which is present along with COVID-19. Number A is acute respiratory distress syndrome. So ARDS onset within 1 week of a known clinical insult. Clinical insult means pneumonia or new or worsening respiratory symptoms. That is within 1 week of a known pneumonia or known development of pneumonia or new or worsening respiratory symptoms. Chest imaging, radiograph, CT scan, or lung ultrasound will show bilateral opacities not fully explained by volume overload, lobar or lung collapse, or presence of nodules. Then origin of pulmonary infiltrates, respiratory failure not fully explained by cardiac failure or fluid overload. And to chest X-ray kami chest imaging ka kan handita kata kanin again respiratory failure umta mayroon sa kang cardiac failure vangi mo fluid over cause dang vangan ni lauti ka kami ka kan identify si chuan mo identify the exclude nuwa cause dang ka kan exclude potang ti chuan chumi nuwa chuan hemi vangi ani ka kan ti thei chawang. Need objective assessment, example echocardiography, to exclude hydrostatic cause of infiltrates or edema if no risk factor is present. So that means if the chest imaging is done and if we see this bilateral opacities or lung collapse, it should not be instantly concluded that it is ARDS. But we have to exclude the possibilities of other diagnoses first, such as cardiac failure or fluid overload. Then under this, oxygen impairment in adults is present. So it is classified into 3: mild ARDS, moderate ARDS, and severe ARDS. So here what we have to see is the ratio of PaO2 to FiO2. PaO2 FiO2 ratio. This is the indicator of hypoxemia. Okay, this is the indicator of hypoxemia, and the normal range is 400 to 500 to 500 millimeter of mercury. So if it is mild ARDS, the ratio will be is usually less than 200 200, and if it is moderate, less than 100, then I'm sorry, there is a mistake here. Mild ARDS, in mild ARDS, the PaO2 FiO2 ratio is less than 300. So as I have mentioned, the normal is 400 to 500. In mild, it is less than 300. But if it is less than 200, it is moderate ARDS. If it is less than 100, it is severe ARDS. Okay. Then oxygen impairment is also seen in children. So here we have to check the oxygenation index, that is OI. Okay, and OI is used to assess the intensity of ventilatory support required. The oxygenation index will give us the value, or it is used to assess the intensity of ventilatory support which is required to maintain oxygenation in a patient. Okay, then but OSI is oxygenation index using SpO2. So if PaO2 is not available, we FiO2 to maintain SpO2 to about 97% to calculate OSI or SpO2 FiO2 ratio. So this can be maintained. Mild ARDS and moderate ARDS and severe ARDS hemi po hi ingani ang classifier nga chuan hemi hi anormal hi hemi ang nauhan children na hianing kalaw identify na law mahi kati swal pala ni anormal kalaw ingay to kasoy may thailawa to wan chuanin anormal to zata khata hang kasoy may thailaw. Then next one is critical disease. Number A, as we have already mentioned regarding ARDS. Number 2 is sepsis. So in adults, acute life-threatening organ dysfunction caused by dysregulated host response to suspected or proven infection. So if there is when there is a suspected or proven infection causing acute life-threatening organ dysfunction, that is known as sepsis, and the signs of those organ dysfunction includes altered mental status, the patient will become delirious, and difficulty or fast breathing, and oxygen saturation will become low, and urine output is reduced, heart rate will increase, but the pulse will be weak. Okay, and skin mottling, it is a it is reddish, and thrombocytopenia, then acidosis, high lactate or hyperbilirubinemia. These are the causes of the signs of organ dysfunction caused by sepsis. And in children, suspected or proven infection and more equals to or more than 2 age-based systemic inflammatory response syndrome SIRS criteria, of which one must be abnormal temperature or white blood cell count. SIRS he can be criteria which includes like tachycardia, tachypnea, fever or hypothermia, and it is abnormalities in white blood cell count. So here it must fulfill this SIRS criteria, and it must include either abnormal. Among these four, there should be abnormal temperature or abnormalities in white blood cell count, along with other features like tachycardia and tachypnea. Okay. Then number C is septic shock. ARDS, sepsis, septic shock. And so septic shock in adults is persistent hypotension despite volume resuscitation. That means by IV fluids or by vasopressors or by administration of blood and all this, requiring vasopressors to maintain mean arterial pressure, to maintain mean arterial pressure at normal range, that is 65 equals to or more than 65 millimeter of mercury, and serum lactate level at the normal level. So septic shock kanti chuanin hemi MAP le mean arterial pressure le serum lactate level anormal la kan maintain thena turatana vasopressor kan manangai china khangatan, that is septic shock. And in children, any hypotension or 2 or 3 of the following: altered mental status, brady or tachycardia, prolonged capillary refill, fast breathing, mottled or cool skin or petechiae or purpuric rash, high lactate, reduced urine output, hyperthermia or hypothermia. Then number D is acute thrombosis. Acute venous thromboembolism, that is pulmonary embolism, acute coronary syndrome, and acute stroke. So these are the four classifications, of these are the four classifications of WHO COVID-19 disease severity. Number 1 is mild disease, symptomatic, that means symptomatic patients without viral pneumonia or hypoxia. Next is moderate disease, that is with mild cases of pneumonia in both children and adults. Then next one is severe disease or severe pneumonia, that means clinical signs of severe pneumonia. Then number 4 is critical disease. Critical disease is classified into 4. Number 1 is with the presence of ARDS. Number 2 is presence of sepsis. Number 3 is presence of septic shock. Number 4 is presence of acute thrombosis. Now coming to variants of concern. Small variations in its genetic code. Variants of concern means you must have heard that there are variants are COVID-19 SARS-CoV-2 variants are emerging, and it is seen in various parts of the world, including India. So there are various. What we have to know is that from the very beginning, mutations has been going on. Mutations has been going on in these viruses. So there are different types of variants, but it is said that all these from their studies, they have found that not all the variants are significant. So there are some variants which are of interest, which are of concern. So these are known as variants of concern. So that means variants of concern, or VOC, means small variants in its genetic code. It does not necessarily mean the virus behaves differently. And we see this among humans all the time. That is, we have different slightly genetic codes. That is why we look different, act different. It does not mean that we are fundamentally different. So that means even if there is emergence of variants among the SARS-CoV-2 viruses, fundamentally, they are still the same. They are still SARS-CoV-2 viruses. Okay. These viruses are not fundamentally different to the previously circulating strains. Tracking the virus through case detection, that means who is infected with the virus, know where the virus is, so that know where the virus is, so that what measures is needed to control the virus can be identified. So to identify and to study or to learn more about the variants of concern, tracking the virus through case detection is very, very important. So if we know who is infected with those variants, then it will be easier to understand what measures are needed to control that virus. SARS-CoV-2 mutations have been identified since the beginning of an outbreak, as I have already mentioned. Then 4 variants which are identified since December 2020, B117, which was first identified in UK, B1351 first identified in South Africa, and B11248 or B1128, or simply it is known as B1. It was first identified in Brazil, and B1617 was first identified in India. And there are also other variants. So these 4 which are mentioned are the 4 variants which are of concern. So as I have already mentioned, there are other variants also besides these variants, besides these 4, but these 4 are the main variants of concern at present. They have differences, these variants of concern, or any kind of variants. They have differences that may affect the way in which the virus binds to human cells, or the way in which the virus can reproduce itself successfully in the human body. What has not changed is how the virus transmits, hence the preventive measures already being adopted are still effective. So from the first point, we can see that there might be variants, but these variants on you must have heard that there is an emerging variants, and the transmissibility of these variants are much higher than the previous ones, the previous viruses. So, but what we have to understand is that they might have been mutated in such a way that it is easier for them to bind themselves to the human cells, or they might have mutated in such a way that they can reproduce more successfully in the human body in larger numbers within a shorter span of time. So that is why the virus load will be higher. So the infectivity will be, the infection chance will also be higher. But at the same time, what we have to understand is that what has not changed is how the virus transmits. Hence, the preventive measures already being adopted are still effective. Irrespective of the variants, the public health and social measures still continue to work at reducing the spread, as I have just mentioned. Diagnostics can still detect cases whether with virus variants or not. So the diagnostic studies which are available right now, they are good enough to identify the viruses, whether they are variants or not. Therapeutics and vaccines still work against all these variants, and research studies are being carried out on the matter. Heta hianin engeni hemi variants to sia thok to lawang vaccine la ka tul to lo ti demo din ba ka I engeni a muthei to khola muthei lo ti te kha thine ni ma se khang kha ani ka ani adik lawani engeni ala muthei a in kan dam doi te pol effective vaccine te pol effective din chu ba ka chan a thei lo han ti tol tur khan engeni hun ala toy mai ni zirna ala tam ala tlem ma amar chu tu na hian I zir reng ani a chumini wan chuan he ayam engani solid knowledge zo kang khachu alaron omle tur thil fum fe zo kalaron chhuak le tur angai ta ila amar chu tu na a chuan heng variants an mu na anga te po hian treatment and pek te more treatment and pek te tin treatment and pek thala effective rengani tin vaccine se pol effective rengani tin ka hemi engani preventive measures can maintain panga engani mask mante good sulfide thati the social distancing khang song song kha effective fekani ti kha an proof ani chumini wan chuan I kan wan nei mani. Increased transmissibility in variants of concern do not imply different modes of transmission, but that these viruses enter the cells more easily. The preventive measures we all know this: wearing masks, social distancing, washing hands frequently, meeting only in places with good air circulation. This is very, very important. I tuna te po in han duty hun te po la omang hostel chon to chanin ngai le ngai khom ni mai thia po lam ne na in mix na khatyang ang eng ma om lo khan I amai ro chu nakina in han chua ke mo hun dang in kalani chu circulation kha chatura ni outdoors ni lo pu in chunga kan ni pun it should be well ventilated space we might have to open the windows, the ventilations, okay? And another thing is that, as I have already mentioned, the virus, how much amount of virus is required to become infective, to cause infection is not known. So many van exposure te kha du tu sama chuan midang te nena kan in biak nge ngai kan in mu nge ngai pun reilo sela mo dark ring za nge min teng zat nge I kan in expose khan and then positive contact ro then phachu I nge ni atlak van doi te po kan ti kha I kan ni kum lama te chuanin kan soi thina I nge ni reilo te in contact te po attended chu and anlo positive kan thowa anlo positive alawi kai chonga amero chu chen khat in chunga cheng ho reng te po kha in kai dar ni alo te po khan ve thawani chumi ni wan chuanin minute engzat nge darker engzat nge second engzat nge in expose nga ya tin chu ba ka positive patient khanin midang avat engeni mode of transmission because I enga po engmo te po khani ta se how much amount of droplets is required di kha khania kha engma sha tala ni lawani chumi ni wang chuanin film khur kha kan ti to berani a social distancing engkim khang jong ha kan maintain tha ang in good air circulation poimo a chuan I midang nena kan in contact angaya ni po in distance kan maintain nga tin it should be kept as brief as possible. And vaccination, good surveillance and laboratory testing is also very important, and good contact tracing, treatment and isolation. Preventive measures ti te vaccine ti tin management te po class in nei dona wangin khang khachu I karon soi lem lo ti mayang thui tak kha karon soi lem lo ani oh so this is all of what I can present. Is there any question? So doing name le nei lo chan du to kang ot khan ta soi thei chin tok ni se
ya zodu kha tu na kan nei tu lo ni pon nakina hemi base hianin I class khala omzel dona I clinical classification te baka thildam nichina so yang khan in the preventive measures ang te po kha le diagnostic test te po kha class khala omzel dona chu wa chon I kan lo chin sia kar karinga tu na zona tu lo ni pon nakina hemi basis sa zona theya kha khami class kan nei huna khan I kan lo ngai poimo don ya chuan hi tuna 11:30 ania alo rom khop be hun toite fel devin miss chatin min lo present saka chuan in timetable kha ka soyang khan jina ka soyang khanin group a kan ron circulate anga class tina chuan kha internal lama external class kha chu alo thei lo ani chuan kan in shathiam mai tora ringa zetir tu de pon arrangement a siam thei thawanga amai ro chu Friday kan ti tur ero hi chu decision nang kan siam deuh lek practical hi chu kan vai hian kan leng thei in ka ring lova chu nak tu ka khan kan lo sha ta tan dar soma khan dar soma changa dar som pania khanin screening of COVID-19 RT-PCR rapid test le diagnosis sakha Dr. Lalhriatpuii in ala dona ni ti kan lo sha deuh na chu wang chuanin pon lamin an la dona tlai lovin kan lut vek don nia ti kan cha non le du ni chuan soitur zirtir tu te changin bidanga changin soitur te omem mo principal om lem lo ani chuan voina tan chuan in tikhanin kan session ma saber chu kan zowa zawai chunga ino de ten vek awangin lom thu kan soyange. Thank you all.
Thank you, Miss.
Thank you, Miss.
Thank you, Miss.